going to talk about the 10 practices for error-free medication administration. It will help you to reduce and even eliminate medical errors. So in this talk, I'll briefly I think only one slide, I'm going to talk about medication safety. And then we'll talk about medication errors, why they happen, the common causes of medication errors, because we need to understand why they happen. And then we can talk about the 10 practices to reduce these medication errors. So what is medication safety? Medication safety is defined as freedom from accidental injury due to medical care or medical errors during medication use process. So it could be the doctors or the nurses who make these errors, or it could be the patient themselves who have these errors. So this PowerPoint or this particular webinar is all about medication errors and how to prevent it. So what are medication errors? These are preventable events. That is the whole point here. And by using these 10 steps I'm going to enumerate, we can actually prevent it. And by not preventing, we will cause or lead inappropriate medication use or even patient harm. They get, allergies or overdoses or all these things are patient harm, while the medication is in control of the healthcare professional or the patient. So both of which are medication errors. Now, if you look at the medication use process, it starts with the prescription. The doctors gives the prescription. Then some places, because the doctors don't directly write it in the order sheet, it is transcribed by some other person and their mistakes can happen. The third is dispensing, which happens in the pharmacy. And fourth is administration, mostly done by the nurses. And fifth is after the administration monitoring. So in all these 5 steps, errors can happen. And let's look at what are all the errors which can happen in these 5 things. In the prescription, the choice of medicine can be wrong, or the doctor may write the dosage wrong. And as you all know, the doctor's handwriting, legibility is a big problem in prescriptions. And transcription can be either mistakes or omissions. Some some drugs may not be transcribed at all. That is the omission. Dispensing, it could be the wrong drug, the wrong formulation being given, or label not being put properly. The administration, I think all of you are familiar with the 5 rights: the patient, drug, dose, route, and time. If any of the rights go wrong, then it becomes a medication error. And as you can see, more than 50% of medication errors occurs at this stage. That is why this webinar, I am focusing on this step alone. The 10 steps I am going to enumerate are to reduce the medication errors or even eliminate the medication errors in this step of medication administration. So you can see the prescription is 20%, transcription is 5%, and dispensing is another 15%. And finally, monitoring is a small percentage, which is around 5%. It could be because of lack of monitoring, or you actually monitor but don't respond to it properly. So these are all the medication errors that occur in the 5 processes of medication errors. Now, it is estimated that 1 in 3 of all hospital adverse events is medication errors. WHO says 2 million hospital stays is affected by this problem, and it prolongs the hospital stay by average to 2 to 5 days, which means it can range between 1 day and 15 days. And 80% of this harm is preventable. That is the tragic part of this. So if you really pay attention, we can prevent most of these mistakes which happen in the hospital. Excuse me. Why medication errors are a serious issue for patient safety? One, as we saw, it can cause patient harm. And very importantly, when such an incident happens in our hospital, there's a loss of trust. Immediately, the press will come and blow it up, and we lose our face and trust in the face of the public. And it leads to increasing cost both to the patient and to the healthcare team. And of course, we'll get entangled into legal and ethical concerns. So these are all problems which can happen because of medication errors. So now, how do we classify medication errors? So the first is called knowledge-based errors. That means, see, these are because we inexperience. It could be a doctor who just joined after MBBS, or a new nurse who just got into, or a new pharmacist. So because of the lack of knowledge, these errors occur. Example is you don't know that the patient is allergic and you give the medicine and they are harmed, or uh, you know, that cloflumampicil is one drug which has penicillin, but maybe you didn't know about it. So these are lack of knowledge or ignorance which can cause medication errors. So these are known as knowledge-based errors. The others are rule-based. What do you mean by rule-based? It is not following the standards, or you know the standards but you take shortcuts. Okay, for example, this classic picture. Even though there is keep off the grass board, you still walk across it. So, for example, diclofenac, that is the Oron, should not be injected into the lateral thigh. That is the standard. But if you do that, then either you are not following the standards, or if you know and still do it, you are changing the standard. So these are known as rules. If you don't follow the rules or if you bend the rules, they're known as rule-based errors. Now, the next is activity-based errors. When you are actually in the process, there are so many things which can cause the errors. One example is the look-alike and sound-alike drugs. So here are two cartons which look exactly almost the same, and there are several standards to make sure that the look-alike, sound-alike drugs are not kept together. They're kept separately and they're labeled to make sure that you're warned about it. Prescription and transcribing errors are also activity-based errors. And finally, memory-based errors, which are also known as lapses. Sudden, you know that last week when the patient came, you remember that the patient is allergic, but this week you're so busy, but you forgot. So these are called lapses, and these are memory-based errors, even though you know sometimes. So these things, the activity-based errors and memory-based errors happen even to experienced people. So there's no, just because I'm so experienced, I cannot say I will not make errors. So errors, error is human. Every human, is bound to make mistakes. So if you are inexperienced, that's what the first thing I talked about, knowledge-based errors. But the rest of the errors also happen to experienced people. So we need to be careful about this. Knowing about how this happened will help us to reduce or eliminate these errors. So the common causes are human factors, which is the most important one. Then there are system factors, environmental factors, and cultural factors. So let's look at each one of them. The first is the human factors. So what are the human factors that can cause errors? One is fatigue, stress, workload of healthcare providers. Now you're in the OP seeing 50 to 100 patients. So, you're not actually as fresh as you were when you started the clinic. So, or all these workload can actually lead to errors. The second is lack of experience. I already spoke about it. Any freshers coming into the hospital, there are more prone to make errors. And miscommunication. Communication is the most important cause of error in general, not only medication error, any error which happens in the hospital, communication is the most important cause. Miscommunication is the most important cause. Then you have mistakes in dosage calculations, documentation errors, and inconsistent practices. If you're not training your team properly, then there will be inconsistency in the practice. One team will be doing one way, another team will be doing the other way, and this will lead to inconsistent practice, and that is another cause for human errors. So, and we continue, as you can see, there's a lot of causes for human errors. Incomplete patient assessment. You don't take proper history about the allergies, current medication. So either there is duplication or you give an allergic drug. Lack of patient education or patient misunderstands your instructions, and healthcare providers are not up to date. So you need to be provided if some particular drug is withdrawn, then all of us needs to know about these things so that we don't keep prescribing it. So if you don't keep ourselves up to date, also medication errors can happen. So these are main causes of human errors. So if you look at system errors, we already looked at this look-alike, sound-alike drugs, and then complex regimens, especially ICU, theater. There are several drugs being given to the patient, and there is more propensity to cause errors. And technology and equipment, though it is helpful, these also can cause problems. And these are some of the system factors that can cause medication errors. Then lack of standardized protocols is another system factor. Poorly organized medication storage, either it be in the pharmacy or high-risk medication or emergency drug, that is your crash cart. If you're not organizing it properly, then medication errors can happen. Now let's get into the environmental factors. One is the noise and distractions. which can interruptions which can happen in the environment, and we should guard ourselves against this to reduce the errors. And finally, very important is the cultural factors. How much of support are we giving for reporting these errors? Once and only if they get reported, then we can learn from these mistakes. So yes, all of we say to err is human, but are we bringing up these mistakes up into the open and learning from them? That depends on the culture of the organization. And sometimes there is more pressure to work quickly because a lot more patients, and you have to keep disposing the patients, we call it, disposing the patients. So when you do that, then it becomes a culture that you don't give adequate time. I still remember, in one of the airports, when I was in the waiting queue, there was a long queue, but that person who was checking in was being pleasant and take its time to check in each one every one of them. And he was looking at the passport, and actually he had a page in which he used to wish that particular person in their language. So, for example, when I went, he said Namaste because from the passport he knew I was from India. So you can see how one person can make a difference in working at their own pace. So very important not to pressurize people to work quickly. And finally, punitive culture. Whenever somebody makes a mistake, you immediately punish them. So once this culture is there, nobody will come out to report errors, and therefore we cannot learn from mistakes. Very important that these cultural factors are put in place. Now, with that background, so we looked at that how humans can make mistakes, knowledge based, rule based, and how there can be slips or lapses which can happen even to experienced people. And then the causes, human factors, systemic factors, environmental factors, and cultural factors. There's so many things which can cause mistakes while we're giving medicines. And as I told you, I'm going to focus only on the medication administration part in this particular webinar. And usually, there is this asterisk, conditions apply. Here, I put an asterisk to say, I will be discussing only low-tech, simple practices that you can implement even from today. I'm not going to talk about any high-tech. I'm not going to talk about anything which costs money. These 10 practices are simple ones which you can just, at the end of the webinar, just write it down and start practicing. So that has been my endeavor in preparing this presentation. So the first step is to follow the 6 rights in the 3 movements. What do I mean by that? All of us know the 6 rights, but what is this 3 movements? Very, very important. Just like in hand hygiene, we say there is 6 steps of hand hygiene, but no point learning about the 6 steps unless you do in the 5 movements of hand hygiene, isn't it? Before touching the patient, before and entering the room, like that. There are 5 movements of hand hygiene. Similarly, in medication administration, there is the 6 rights. Now there are 6 rights, 8 rights, 10 rights. I'm focusing on the 6 rights, which are very, very important. But we have to do it in these 3 movements. Very important. I want to point out that. So these are the 6 rights: the right patient, the right drug, the right dose, the right route, right time, and right documentation. Now, what are these 3 movements? So you know, when administering the drug, first you're going to take the drug out of storage. That is the first moment. So at that moment, you need to verify the right patient, the right drug, and also the right dose, because the right preparation. Are you taking 50 milligram or 25 milligram? So these 3 things. And are you taking the right route? Are you taking the injection or are you taking the tablet? Okay. So these things should be double checked when you take the drug from storage. The second moment is while preparing the medication. So when you're either mixing a drug or loading into a syringe, that is the preparation. So you look at whether you're the prescription of the patient, the right drug, the right dose, and the right route. And finally, before administering to the patient, you got to look at all the 5. That is the right patient. You look at the wristband and check it with your drug chart to make sure you're the right patient. Look at the prescription and make sure the right drug, the right dose, the route, and look at the clock to see whether you're giving it at the right time. And finally, document all of these. So these 3 movements, after taking the drug from the storage, before preparing the medication, before administering drug to the patient, you got to look at these 5 rights and document it. Okay, so that is the first step. Now, first way in which we can reduce these errors. The second is choose the appropriate double check. So all of us know about, we commonly do the 2% double check, but there is something called independent double check. I wanted to point out that to you. So 2% drug checking is one staff will read out the product details, patient identification details, and the second person will confirm, yes, yes, yes. The task is shared and the process. So what they're saying is the drawback in this is because there are 2%, who's actually responsible? So one person will think, yeah, that person is responsible. The other person will think, no, the other person is responsible. Because of this, mistakes happen. So there is no sole responsibility in the 2% checking. It is good. No, there are 2%, definitely the errors come down, but this is a drawback. So because of this drawback, they said, why don't we do double independent checking? So many hospitals are implementing this double independent checking where you check the drug, all these patient details, or there are 5 rights first, and then another nurse or doctor will come at a different time, maybe 5 minutes or 10 minutes later, and again check the same things and make sure you have done the right thing. Okay, so the first independent checker will correct all the errors before the second check, and the second person will come and see whether you have done all that right. So here each person is solely responsible, and they say that this will actually improve the or reduce the medication errors which are happening. But this has got drawbacks because it takes time and it is repetitive. So not when you have high volumes of patients, this is not possible. It is much easier to get 2 people, check it and get the work done. So it depends on your organization. If you're like a small one center where your volume is low, 2% double checking. I mean, independent double checking can be done. But if you're high volumes, lot of patients you got to see, a 2% checking can be faster, and you can still make sure you have a process to reduce medication risk. Both are good. Both have got drawbacks. So remember that. So, but do appropriate double check for high risk medication and emergency drugs, look-alike, sound-alike drugs, things like chemotherapy, narcotic drugs, all these things have to be double checked before giving. So as I said, it has got advantages and drawbacks. Now, checklists, many of you had said no, use checklists. So make a checklist so that you make sure that you have gone through all the things. Has the patient been identified? Drug name has been verified. Drug dose has been verified. Route has been verified. Time given is correct. So if you use a checklist, then you can use it for auditing, and thereby you can look at how many times that these mistakes happen. So the third way to reduce medication errors is to use checklists for the 5 rights. Now, the fourth is distractions. As I said I'm not going to do any high-tech method. This is very simple. Either you draw a red line, and Lakshman Rekha. If the nurse is stepping into this area, that means that nurse should not be interrupted. She is doing medication administration and nobody should disturb. Or if you want to spend a little bit more money, you give them these vests saying do not interrupt or do not disturb nurse on medication wrong. So these two are very simple ways by which you put a system in your hospital, and the nurses know, the rest of the people also know that when that nurse is doing, we should not interrupt. It may be the senior most doctor doing the rounds, but still when they see this nurse standing in the red line, they should respect it and not disturb the nurses. So that is the fourth step in avoiding medication errors, avoiding distractions. The fifth is actually using a little bit of technology, this automating drug calculations. So all of us have the mobile phones, and I want to you to maybe just take a photo snapshot of this two sites. One is called the drug calculator, another is the infusion calculator. This, you only have to input the patient's drug dosage, the weight, and all those things. Automatically, they will calculate. Some of the senior nurses may frown on this because they say, the nurses have to calculate. Yes, I do agree. You have to teach them to calculate. They should know how to calculate. But still, in terms of reducing medication errors, use these simple devices, which you always have the phone in your hand. Instead of watching Netflix and Instagram, use it for these sort of purposes where we can reduce medication errors. So the fifth way to reduce medication errors is to automate drug calculations, by which is available. Download this app in your mobile phone. It is available both for iPhone and Android, both these, and you can help you to reduce errors in calculation. As you pointed out in the poll, this is the most difficult part of medication administration. Many of you pointed that out. So this is something which you can use. The sixth is, when taking telephone orders, there is a process called read back. So what is read back? That when I say give 20 milligrams of insulin to this patient, you got to read back saying, you don't say 20, you say 20, because 20, or 20 is fine, but these teen numbers, 14, 15, 16, 18, or can be confused into 18, can be confused as 80, like that. So the read back helps to clarify these things. So it should be practice. It should be in your SOP. It should be in your manual, and it should be in your training. And make sure all the doctors also encourage read back. The same way all the nurses do the read back when they take phone orders. So you have to listen actively, repeat it, get confirmation, write it down, and then read it back. So it is not repeat back, it is read back. Read back means you have written down what the doctor has told and you read what you have written. Whereas repeat back is just like parrot, repeating what I'm telling. You've got to do that initially, but only when the read back happens, that is what you have written, you have read back, then only the errors will come down. Many people are confused about it, between repeat back and read back. That is why I wanted to clarify. So repeat back is just verbally repeating what I told, whereas read back is writing what I told and reading what you written. That is known as read back. And once you read back, the other person confirms it, you have done the read back properly. So sixth step, or sixth way, I won't say step, it is a sixth way to reduce medication errors, is to practice read back when taking telephone orders. The seventh is avoiding dangerous abbreviations. So there are certain dangerous abbreviations. The most common thing is writing units. Insulin, you write 5 units. Instead of writing UNITS, I write U, 5U, and somehow that U looks like a 0. So the nurse thinks it is 50. She draws up 50 units of insulin and gives it to the patient. This is, I'm not making this up. It has happened several times. Okay. Like that, there are certain dangerous abbreviations that you must not use in your prescription or in your transcription. So here is the list given by the Institute for Safe Medication Practices. You can Google it, ISMP, Institute of Safe Medication Practices site will give you a list of high-lead medications or dangerous abbreviations. All these they have. So this, the list of abbreviations you take from them. All of them may not be appropriate to your hospital. Take the ones which are appropriate to your hospital. Make a list of dangerous abbreviations for your hospital. Put it into your policy and train people not to use it. So the seventh way to reduce medication errors is avoiding dangerous abbreviations. The eighth is to organize a medication storage. So what do I mean by medication storage? There are three things mainly. One is high-risk medications. High-risk medications are those which have a very narrow therapeutic window. If you give a little bit higher dose, it is dangerous. If you give a little low dose, it doesn't work. Classic examples are insulin, potassium, and also drugs like very highly concentrated drugs like sodium 3% and chemotherapy agents and TPN and things like that. And also psychotropic drugs like narcotics and other psychiatric medications. So these are high-risk medications. You need to store them separately. You need to put a label saying this is a high-lead medication, not only on the container, but on each and every ampule and vial, to make sure that they know that this is high risk. And as I said, this should be double checked and then only administered. Emergency medications are stored in the crash cart. The thing is, you got to store uniformly. You may have 12 or 50 crash carts in your hospital. If I open the top right drawer in any of the crash cart, in the hospital and put my hand into the front compartment, I should take only that particular drug. It should be epinephrine and nothing else. So this uniformity in storing the emergency medications in the crash cart all over the hospital will reduce medication errors. Or otherwise, in the hurry, because in one ward you found that this particular medicine was in the top right drawer in the front compartment, you will blindly go pick it up and give it, and that will cause medication errors. So very, very important to organize your crash cart uniformly so that all the crash carts, the storage is uniform. And lookalike, soundalike already pointed out that they have to be stored separately, and also you can do what is known as tall man lettering. You that particular thing which is which is very unique to that, you put in capital letters. So here you can see methyl prednisolone is put in capitals, whereas solu and is the SOLU. So you won't make a mistake. And also put a label saying this is a lookalike, soundalike. So you have to be careful. So these are ways in which you can organize a medication storage to reduce medication errors. So coming to the ninth way is training. I think this is very obvious. So take up the most important, even if you're not telling all the things. Very simple is use these 10 steps, 10 ways to reduce. That only looks at medication administration, but we have prescription, we have dispensing, and all those things. So each particular department, for the doctors, it will be different, focus. For the nurses, it will be different focus. For the pharmacy, it will be different focus. So this, sort of training should be given to educate your staff on medication errors. And last but not the least is to educate the patients, because as we saw, medication error is also happens because the patient is not aware of it. So WHO has, now we all have this 5 movements of hand hygiene, and I told about the 3 movements of using the 6 rights. So for the patients, WHO has come up with the 5 movements. So you should tell the patient before starting the medication, what is the name, what is it for, what are the risks and side effects, and the patient should also how often they should take, what they should do if they have side effects, and if you're adding a medicine, what is the justification for adding, and if there's any interaction between the various medicines, and how long the medicines should be taken, and when should I stop the medication. All these things should be clearly educated to the patient and encourage them to engage themselves in their medication usage, not blindly take what you have told. So that's very important. That's the 10th. So I'm going to give you a bonus 11th. As I pointed out earlier, building a blame-free culture. Very, very difficult in the Indian environment. All of us have been brought up in a punishment in the school. I mean, our generation, it was physical abuse. Current generation is verbal abuse. That is the only difference. But we keep blamed, for each and every mistake we make. And this keeps on continuing in the workplace also. So instead of blaming, you give adequate support for reporting and learning from errors. And reward safety than quick work. Don't whip them to do quick. Why are you so late? Why are you taking so much of delay? Instead of saying that, encourage them to be safe. Of course, they can't be very slow, and they also need to be efficient. But the focus should be on safety rather than quick work. And learning versus punitive. Don't jump on people the moment they make a mistake and stamp them down. This happens all the time. No, why did you do it? No, don't you know this is such a simple thing? No, this sort of thing will make them ashamed of themselves, and they will never come out with any of the errors that make. It is all be under the carpet. So unless you say, okay, it's fine, everybody makes mistakes, but make sure it doesn't happen in the future. Counsel them and ask them to report it, and you can then learn from mistakes. So the 11th step or 11th way is building a blame-free culture. It is not easy, but we need to try to do this. So friends, I think it's time to summarize. So let me now do it in a quick way. So you have to use the 5 rights in the 3 movements. You've got to double check, either it is 2-person or independent double check. You decide according to your organization. Use checklists for whatever medication process where you think it is difficult. So people now go through it in an organized manner. Avoid distractions using simple measures. automate calculations. Use that mobile phone and use those apps which are free to make, to reduce the errors. And sixth is practicing read back when you're using the phone, avoiding dangerous abbreviations, organizing your storage is the eighth, training the staff is ninth, and educating and engaging your patients is the 10th way. I hope this is useful. I think, as promised, I don't think any one of these requires a lot of money. It will require a little bit of effort and time. But these are all very simple things which you can practice from today. And by doing this, as I pointed out, 80% of medication errors can be prevented. And let us make an effort to reduce these medication errors in our hospital. Thank you so much again for your attention and staying so long with me. And goodbye, everyone.